Hi viewers, I am Bijoy Ajayan, 2012 Mbbs batch, Government Medical College, Trivandrum. In the previous video, we have seen in detail about the motor system, the differences between the upper motor neuron and the lower motor neuron, as well as the sensory system. So now the patient has come to you with weakness, right? So we were talking about a patient who come to you with weakness. So you have now analyzed him and you have came to a conclusion that the lesion is in the pyramidal system. It is an upper motor neuron lesion, and now your objective is to find out where exactly in the upper motor neuron pathway is the lesion. That is, now you have to start to your localization process, right? I have already started. It is a UMN lesion, right? So now where in the UMN pathway? Is it in the cortex, or is it in the internal capsule, or is it further downwards in the brainstem or the spinal cord? So like that you need to localize the lesion, right? So in this video we will deal with the cortex. So when we say about the cortex, you know that cerebrum is the largest part of the human brain, and we have two cerebral hemispheres which are controlling the opposite halves of the body, right? And the cortex is nothing but a surface of gray. It is a surface layer of gray matter that consists of the cell bodies of the neurons. And so I have told you there are two cerebral hemispheres. Now these hemispheres we can divide it into two, that is the dominant hemisphere as well as the non-dominant hemisphere. The dominant hemisphere is also called as the categorical hemisphere, and it is involved in controlling the speech, logic, analysis as well as calculation. And we have the non-dominant hemisphere that is also called as the representational hemisphere, right? And this is involved in spatial orientation, music as well as art forms, right? So when a patient comes to us, how do we identify which is the dominant hemisphere? So first keep this concept in mind that among the in general population, about more than 90 to 95% is of the population is right-handed, while among the right-handed persons, more than 90% again has a left hemisphere dominance. Also, among the left-handed persons, about more than 60% of them, of the left-handed persons, again have their dominant hemisphere as the left hemisphere, right? So remember that the left hemisphere is the dominant hemisphere in the population. So to know which is the dominant hemisphere, you have to, there are several methods. One common method is by assessing the handedness, as I have told you, right? First of all, you have to assess the handedness of the patient. That is why in higher mental functions you are first asking for the handedness of the patient, right? So by assessing the handedness, you can ask which hand does the patient use to comb his hair, to throw as well as catch a ball. Like that you can ask the patient, right? And another specific test to detect the handedness is WADA test, W-A-D-A test. That is nothing but you are injecting a short-acting barbiturate. Usually it is sodium amobarbital into the internal carotid artery of the patient. So if the left hemisphere of the patient is dominant, then you are injecting it into the left internal carotid artery, then the patient will develop transient aphasia. That means transiently he will be having the dysfunction of language, right? So the patient will be developing transient aphasia. So that is a specific test or the gold standard test for detecting the handedness. And this handedness comes mainly where before you do a neurosurgical intervention, right? So that is about the handedness, right? So now we have to know about the functional areas of the cortex. What are the functions of different areas of the cortex? That is our primary objective, right? So you know, this is the superolateral surface of the cerebral hemisphere, and this has got many functional areas. You have the central sulcus, anterior to it you have the frontal lobe, the parietal lobe, and here you have the occipital lobe as well as the temporal lobe. So you have all the four lobes here, right? So we will take each lobe and assess what are the functions and what are the lesions that would happen in each lobe. Right. So this is again the same thing. So the frontal lobe extends from the frontal pole up to the central sulcus, from the frontal pole up to the central sulcus, right? And anterior to the in the frontal lobe, anterior to the central sulcus, in the precentral gyrus, we have the primary motor area. As you know, the primary motor area is involved in voluntary control of the motor activity in the opposite half of the body, right? And a lesion in the primary motor area would result in contralateral hemiparesis. Now, there is a premotor area near to the primary motor area, the area number 6, right? So the premotor area, what is the function of premotor area? It programs the intended movements. It is responsible for the planning as well as programming the intended movements of the primary motor area, right? So that whatever, for example, if a person decide to take a step, he want to walk forward, he want to take a step. So first the neurons in the premotor area are being stimulated. So that is for, you have to plan. The brain is planning the motor activity. What has to do, what it has to do, what the primary motor area has to command in order to achieve that idea, right? So that is the premotor area. Now, a lesion in the premotor area will cause there will be difficulty in performance of skilled movements, especially the skilled movements will be more difficult in case of a lesion in the premotor area, right? And one more important thing, in the primary motor area, the human body, the entire human body is represented in an upside down fashion, like this. Here comes the head, right? Then the hands and the trunk and the legs. So in an upward, in an upside down fashion, the human body is represented in the in the primary motor area, right? And this is called as the motor homunculus, right? This is the exact representation. This is the motor homunculus. That is, you have the pharyngeal region as well as the tongue in the lower area, and then you have the face, you have the hands and the thumb, the face, the lips, as well as the thumb has got a greater area of representation, and then you have the trunk and also the thighs. And now the leg, feet as well as the perineum, they are on the medial surface. This we are talking about the superolateral surface, right? This surface, this is the superolateral surface. The other one inside, this is the inframedial surface. So that is the medial surface. On the medial surface you have the paracentral lobule, and so the legs, feet as well as the perineum are represented on the medial surface of the hemisphere, right? Now another important area is the frontal eye field. So what is the function of frontal eye field? Frontal eye field controls the voluntary conjugate eye movements to the opposite side. That is, without turning the head, the person, see, this person wants to look to his left without turning the head. So we can see that this eye should abduct and this eye should adduct, right? So that is called as the voluntary conjugate movement. So this frontal eye field controls the voluntary conjugate movements to the opposite side. That is, this is the right hemisphere that is controlling his voluntary conjugate movements to the left side, right? And lesion here will cause the eyes of both the sides to deviate to the side of lesion. That is, if there is a lesion, the person will not be able to look to his left. In the right lobe, if there is a lesion, if the person will not be able to look to his left, so the eyes will deviate to the side of the lesion, that is to the right side, and there will be inability to turn the eyes to the opposite side, right? So that is the frontal eye field. Now in the frontal lobe you also have the Broca's areas, right? This is the motor speech area. So we will talk about more it later. So anyway, remember that this is Broca's areas are present in the inferior frontal gyrus of the dominant hemisphere. Only in the dominant hemisphere you have the Broca's areas, and this is the motor center for speech. Whatever lesion is there, it will cause inability to produce speech, right? The fluency of the patient would be impaired. And then another very important area in the frontal lobe is the prefrontal area, right? So the prefrontal area, it is concerned with the personality of the person, the emotional as well as the social behavior of the person is being controlled by the prefrontal area, right? And also it is the prefrontal area that inhibit the primitive reflexes which are present in the newborn. See, in the newborn you have got several primitive reflexes. These reflexes, become, it will be present in the initial stages. Later on it will disappear. It is because the development of the prefrontal area has developed. It has inhibited the primitive reflexes in that which are present in the newborn. So that is why we need to check while we are checking the reflexes, we need to check the primitive reflexes also. We should check if there is any reappearance of this primitive reflexes. If there is a lesion in this area, the primitive reflexes will reappear, right? And also I'll tell you the lesion. I have told that the prefrontal area is concerned with personality, the emotional and social behavior, right? And if there is a lesion, this will result in profound change in the personality of the patient. There will be loss of concentration, initiative, judgment, everything will be lost, right? And the person becomes careless about his dress as well as appearance, and there will be inappropriate social behavior, like the person will just use any obscene languages, and also he will urinate in the public. So like that, the prefrontal area lesion will cause such, what you can say, inappropriate social behaviors. So the prefrontal area is very important, and also whenever there is a lesion, it will cause reappearance of the primitive reflexes. So you can see here, let us see some of the primitive reflexes. The snout reflex, you have to lightly tap the lips, and abnormal response is lip pouting, right? So you can see here. See, once you are touching the lips, the lip is pouting, right? So that is snout reflex. Then another reflex is the palmomental reflex. That is, you are applying firm pressure to the palm and on the thenar eminence, next to the thenar eminence, and an abnormal response is ipsilateral puckering of the chin. You can see in this video, right? While he is rubbing on the thenar eminence, there is a twitch. Look at the chin. Yeah. Right. You can see the puckering of the chin. So that is the palmomental reflex. Now another important thing is the glabellar tap, right? For the glabellar tap, you have to stand behind the patient and tap repeatedly between the eyebrows with the tip of your index finger. Normally, the blink response will stop after 3 or 4 taps, but in case of patients who are having this primitive reflex, the release of primitive reflex, they will keep on blinking. See, you can see that the person is blinking. As long as you are tapping, he is just blinking like that, right? So that is the glabellar tap. Another reflex is the grasp reflex. That is, you have to firmly stroke the radial side, palm on the radial side, and in abnormal response, your finger will be grasped by the patient's hands. See, all these reflexes are seen in a newborn, and these reflexes will be absent as the newborn grows, right? And now another important area in the frontal lobe, that is on the infromedial surface. So we were seeing the superolateral surface, right? And on the infromedial surface, we have the paracentral lobule, right? So what is the function of paracentral lobule? That it controls both the motor as well as sensory innervations of the contralateral lower extremity, right? So both motor and sensory innervations, as well as it is also involved in regulation of micturition, that is voiding of urine, as well as defecation. So what does a lesion cause there? If there is a lesion, that will cause loss of power in the contralateral leg, as well as cortical sensory loss in the contralateral leg, right? Both motor and sensory loss, because the motor area is there and the sensory area is also there, right? Then also there will be very important urinary as well as fecal incontinence is also there, right? So that is the lesion of the paracentral lobule. So once again, the frontal lobe, you have the primary motor area, the premotor area, the frontal eye field that helps in voluntary conjugate gaze, the motor speech area, that is for the Broca's area, that is the motor speech area, and you have the prefrontal area, and on the medial side you have the paracentral lobule. So these are the main areas in the frontal lobe, right? Now we will go on to the parietal lobe. So in the parietal lobe, this extends from the central sulcus to the parieto-occipital fissure, right? From the central sulcus up to the parietal occipital fissure. Now, in the parietal lobe, irrespective of the dominant or non-dominant hemisphere, you have the primary somatosensory area, right? So this primary somatosensory area, it is involved in control. This primary somatosensory area that is present in the postcentral gyrus is involved in the cortical sensations. The cortical sensory area. So it receives cortical sensations from opposite half of the body, and a lesion here will lead to contralateral hemisensory loss will be there. And remember that near the primary somatosensory area you have the sensory association cortex, right? See, with each primary sensory modality, let it be the sensory area or the auditory area or the visual area, you have certain association areas, right? See, visual association areas and secondary auditory area, the auditory association areas, and also you have the sensory association area. So what is the function of these association areas? See, this association area, it is involved in the pattern recognition. To recognize, you need this area, right? Recognition, and it allows to perceive the object based on the sensory information that is received by the primary cortex, right? Based on what the sensory information the primary cortex receive. If you want to recognize that, for example, what we say of stereognosis, right? So for example, if you want to take a coin from your pocket, you will be putting your hand in the pocket. You are not seeing the coin, but by the feel of that coin, you are able to recognize that this is a coin. So this recognition comes from the association areas, right? So that is the function of this so that is the function of sensory association cortex. So stereognosis as well as graphesthesia. So in the previous video I have told you about both these things, right? Stereognosis and graphesthesia, both will be impaired. There will be a stereognosis, that is inability to identify the object, identify a familiar object by its feel, and agraphesthesia will also be there. And also I have told you it is the cortical sensations, and here the cortical sensations will be lost, that is the tactile discrimination, the tactile localization, the stereognosis, the graphesthesia, all this you are checking, right? So all these things will be lost. Now, so that is the parietal lobe, irrespective of whether it is dominant or non-dominant, right? So in the dominant parietal lobe, now we are coming to the dominant parietal lobe. In the dominant parietal lobe, you have the sensory speech area of Wernicke, or the Wernicke's area. So the Wernicke's area is the sensory speech area. Now what is the function? The interpretation of the language through visual input. We will deal it in a minute. And the lesion will cause Wernicke's aphasia, right? And also there can be apraxias also. That also we will deal it in a minute. Then see, if the lesion in the dominant parietal lobe, if the lesion is confined to the angular gyrus, that is the area number 39, right? To the angular gyrus, this results in the inability to read, that is called as alexia, and inability to write, that is called as agraphia, right? Inability to write, inability to read. And this is often seen with a constellation of symptoms with 3 other unique symptoms. What are those symptoms? There will be acalculia, that is calculation is impaired. There is loss of ability to perform even the simple arithmetic problems. And finger agnosia will be there, that is inability to recognize one's finger. And there will be right to left disorientation. So this constellation of symptoms that appears in the lesion of the dominant parietal lobe is called as the Gerstmann's syndrome. Right. So the dominant parietal lobe, you have the aphasia, the apraxia, and also the Gerstmann syndrome, right? The constellation of symptoms. So that is about the dominant parietal lobe. Now, what are the features in the non-dominant parietal lobe? Let us see what are the symptoms that a patient would be having if he is having a lesion in the non-dominant parietal lobe. So, the integration of visual as well as sensory information is very important for the formation of a body image in our brain, and also for the awareness of the body and its position in the space, right? So for that spatial orientation and to identify the body, for the awareness of the body as well as its position in space, the visual as well as the sensory information should be integrated, right? And so lesions in the area of 39, 40 as well as 7. So this is the superolateral surface of the dominant hemisphere, right? That is why this is the Wernicke's area, right? So in the non-dominant hemisphere, the lesions in these areas, what will happen? There will be unawareness or neglect of the contralateral half of the body, and this is called as asomatognosia or hemi-neglect, right? So even though the patient, his somatic sensation is intact, he will ignore the opposite half of the body, right? For example, he will forget to dress the opposite half of the body. He will forget to shave his face, on the opposite half, right? So this patient is having a right-sided brain injury, and this patient has developed left-sided hemi-neglect. The opposite side there will be hemi-neglect. Okay, so that is the non-dominant hemisphere. So the patient is developing is with a left-sided neglect. So the person does not shave dress on the left side of the body, or shave his left side of the face, or does not eat anything from the left side of the plate. So that world is completely absent to him, right? So the left side. And if the patient, even the visual field is intact, you know, the somatic sensations are intact, the visual field is also intact. Even then they deny the existence of the things that are present in the left visual field, right? So if they are asked to copy a flower, they will copy like this. They will not draw it on the left side. And if they are asked to circle the letter A from this puzzle, they will just circle the letters, the A on the right side. They will leave the left, right? That is left-sided hemi-neglect. And if they are asked to draw the face of a clock, they will just draw like this from 1 to 12 on the right side. They will forget the left side, right? So that is hemi-neglect. So, and even, you know, the patient may deny that the left arm doesn't deny that, you know, if you say this is your left arm, the patient will say no, it is not my left arm, right? So like that, even if the limb is brought to his vision, he will say this is not my arm, right? So like that, that is the asomatognosia or hemi-neglect. Now this is often associated with anosognosia. What is anosognosia? That is, the patient does not accept the disease. They also deny their deficit. If you are saying the patient is having deficit or the disease, they won't agree. So that is anosognosia, right? So these are the major things. And also you have constructional apraxia and dressing apraxia. That also we will see. And the spatial orientation is lost, and hence there will be spatial disorientation. Now coming to the temporal lobe. So we have seen about the parietal lobe, the common, that is the sensory areas, and the dominant parietal lobe as well as the non-dominant parietal lobe, right? So non-dominant parietal lobe, you will be having the spatial disorientation, the constructional apraxia, the dressing apraxia, as well as the hemi-neglect or asomatognosia, right? And now we will come to the temporal lobe. So in the temporal lobe, you can clearly see here, you have the primary auditory area, right? Area 41 and 42. So unilateral destruction of this area will result in slight loss of hearing, while if there is a bilateral destruction, that will result in cortical deafness, right? So this area, it is the primary auditory area. Now the auditory association area, right? That is the area number 22. So that is for recognition. I have told you, for recognition as well as recall of the sounds. So what will happen if there is a lesion in the secondary auditory area? There will be auditory agnosia, right? Auditory agnosia, that is the inability to recognize the meaning of the sound despite having a normal hearing. So this can either involve language, that is hearing words but not knowing what they mean. That is pure word deafness, right? You are hearing some words but you are not able to understand what is it. Hearing is normal, but you are not able to recognize it, right? So that is pure word deafness. Or it can be non-language, that is a person who is so familiar with an instrument, with a musical instrument. Now after this lesion, he is not able to recognize the sound of those musical instruments. So that is non-language. So that is auditory agnosia. Auditory agnosia is a feature of this temporal lobe lesion. And then again, as we say in the parietal lobe, in the dominant temporal lobe, if you have the vernix area is also extending into the temporal lobe. So there will be lesion will cause vernix aphasia. Again, non-dominant hemisphere. I have told you the non-dominant hemisphere, it is mainly controlled with music, right? The music as well as the art forms. So there will be impaired musical skills if the temporal lobe is impaired, right? And then on the medial side, right, as well as inferior surface of the temporal lobe, on the medial as well as the inferior surface, as inframidial surface, right, of the temporal lobe, you have the uncus, the hippocampus, right, the parahippocampal gyrus, the uncus, the hippocampus, the amygdala. So all these structures are present in the temporal lobe. Let us see what will happen if there is a lesion to them, right? So remember that uncus is concerned with the olfaction, smell, right? So if there is a destructive lesion, it will cause ipsilateral loss of smell or anosmia. And if there is an irritative lesion, that will cause olfactory hallucination, that is seen in temporal lobe epilepsy. See, the person will smell something and suddenly he goes into unconscious state, right? That is because of, that is a particular type of seizure. He smells, for example, he will smell the smell of a rose and suddenly he will say that he has lost his consciousness. So that is nothing but temporal lobe epilepsy or uncinate fits, right? That is seizures beginning with the crude sensation of the smell. So that is the thing with the uncus, if there is a irritative lesion in the uncus, right? And now the hippocampus. So what is the function? What will the hippocampus is mainly concerned with memory, right? And so what will be there if in cases of bilateral lesions of the hippocampus, there will be anterograde amnesia, right? So what is anterograde amnesia? It is the inability to form new memories, or you can say more clearly that inability to consolidate the short-term memory into the long-term memory, right? So this is shown in a famous film. I hope most of you have watched it. That is Gajini. The same thing is being shown, right? So that is anterograde amnesia. The person is not able to form the new memories. He's having a short-term memory loss, but the earlier memories can be retrievable. So this is anterograde amnesia caused in bilateral lesions of hippocampus. And then the bilateral lesions of the amygdala. In cases of bilateral lesions of the amygdala, you will be having the Kluver-Bucy syndrome. What are the features of Kluver-Bucy syndrome? There will be hyperphagia or compulsive eating will be there, and hyperorality will be there. That is an oral tendency or compulsion to examine the objects by mouth, right? And there will be hypersexuality, that is increased sex drive, and there will be visual agnosia, right? That is inability to recognize the familiar objects or people. So there will be visual agnosia that we'll see. And also in case of the visual radiations, right, in the temporal lobe, there will be contralateral upper quadrant anopia. So we will see this when we are dealing with the visual pathway. And finally, the occipital lobe. So in the occipital lobe, you have the primary visual area, that is for the reception of the visual image, right? And if there is a lesion in the visual area, that will lead to contralateral homonymous hemianopia, right? On the opposite side, there will be homonymous hemianopia. That is again a visual pathway defect, right? And in the visual association areas, you also have the visual association areas. So a lesion in this area causes visual agnosia. What is it? Visual agnosia, that is the inability to recognize visual objects despite having an intact primary vision. The person is not able to recognize. For example, if you show him a pen or a cup, he is not able to recognize, right? So that is called as visual agnosia because there is a lesion in the visual association area. And an extreme form of visual agnosia is the prosopagnosia. Prosopagnosia, right? So that is, what is prosopagnosia? That is nothing but inability to identify a familiar face. The person is not able to identify a face that is familiar to him. That is prosopagnosia, right? It's a form of visual agnosia. And this was popularized by in a book that is written by Oliver Sacks, that is The Man Who Mistook His Wife for a Hat. If you get time to read the book, you can read the book. Fine. So we have dealt with all the four lobes, all the functional areas in those lobes. What are the functions of these areas and what are the lesions? What are the after effects of the lesion in that areas, right? So this all helps you to localize the lesion in the cortex. So again, so a patient has come to you with the cerebrovascular accident. Now, how would we localize that a lesion is there in the cortex? So we have to check for the following symptoms. That is, if the person is having an altered sensorium, if the person is having seizures, aphasia, agnosia, apraxia, as well as loss of cortical sensation. So while you are taking the case in your final year practical examination, you are finding if any of these are present in the patient, directly you can say that the lesion is in the cortex. You can be pretty confident to say that the lesion is in the cortex, right? So we will see this one by one. So altered sensorium. So what is sensorium? Sensorium is nothing but the intelligent awareness of self and the environment, and the person is able to respond to the changes in the environment, right? So the awareness of self as well as the environment, that is the sensorium. So if the person comes with altered sensorium, that means there is some problem with the cortex. So this is remember this table. In this table by this table you can easily identify at what stage, at what level of consciousness does the patient has, right? Depending on if the patient is responding to you spontaneously, or if the patient is responding to you on verbal stimulus or on painful stimulus, right? So we can divide the level of consciousness. So first one is, you can say the patient, when do you say the patient is alert? When he is having a spontaneous response. As soon as the patient sees you, he talks to you, that is a spontaneous response, right? Then you can say that the patient is alert. Then when will you say the patient is drowsy? The spontaneous response is gone. Only when you are talking to him, okay, when you are giving a verbal stimuli, he will be able to respond. So that is called as drowsy. Now what happens in case of stupor? The spontaneous response is gone. The verbal stimuli is also gone. You are calling him, he is not responding. But if you give a painful stimuli to him, he will respond, right? He may groan, or sometimes he may respond, right? So the painful stimulus, you can give it in the middle of the sternum, right? So like that, if you give a painful stimulus, if he is responding, you can say that the person is stuporous. Now, what if the patient is not responding to the spontaneous response, verbal stimuli as well as painful stimuli? Now you can say that the patient is in a state of coma, right? So these are the level of consciousness, that is the altered sensorium of the patient. This is how you assess the altered sensorium of the patient, right? Now there is a Glasgow coma scale, that is for analyzing how much response the patient is having, right? So there are three parameters, that is the eye opening, the verbal response as well as the motor response, right? So eye opening response, there are 4 scores. You have 5 in verbal response and 6 points in motor response. So eye opening, if the eyes open spontaneously, you can give 4. If it opens only to verbal command, 3. And if the eyes open to pain, then 2. There is no eye opening, it is 1. Remember, this is 1, not 0, right? It is 1 point. So that is, so the minimum point is 1, 1, 1. Total, the minimum is 3, right? So verbal response, if the patient is oriented, you can give 5. If it is confused, conversation is there, right? Confused conversation, but the patient is able to answer the questions, you can give 4. And if there is inappropriate response, but the words are discernible, then you can give 3. And incomprehensible sounds or speech, 2. And if there is no verbal response, then 1 point. And again, motor response, if the patient is obeying your commands for movement, then 6. If there are purposeful movements, right? If you give a painful stimulus and you feel that the person is making purposeful movements, then you can give 5. If the person withdraws himself from the pain, then you can give 4. And if there is abnormal spastic flexion, also called as decorticate posturing, right? You can give 3. For decerebrate posturing, 2. And for no response, 1. So if it is a 13 to 15 points, it's a minor brain injury. 9 to 12 points, it is considered to be a moderate brain injury. And 3 to 8 points, it is severe brain injury, right? So let us see these two terms, decorticate posturing and decerebrate posturing. Often in coma patients, you hear these two terms, right? What are these? See, decerebrate posturing means there is postural extension of both arm as well as the leg. See, there is arm, both the arm, the elbow is extended, there is hyperextension of the knees, there is plantar flexion, right? Complete extension is there, right? This is called as decerebrate posturing. So this indicates the dysfunction of the upper brainstem, right? So this indicates the dysfunction of the upper brainstem between the superior colliculus, right? Between the superior colliculus as well as the vestibular nuclei in the pons. That is this green area, right? So this area, if there is a problem, that would result in decerebrate posturing, right? So what is there? Here you have the red nucleus as well as the rubrospinal tract, right? So this, both red nucleus as well as rubrospinal tract are both included within the lesion. So that results in decerebrate posturing. That is up in the upper brainstem. That is in the midbrain. The lesion is in the below the midbrain. That is in the superior, between the superior colliculus as well as downwards. And if the patient is having decorticate, and another posturing is the decorticate posturing, right? That is, there is postural flexion of the arm. See, the elbow is flexed, but again the legs are extended. So this is seen in the lesions that are above the midbrain, right? So decerebrate posturing is below the midbrain, but decorticate means it is above the midbrain, right? So above the midbrain, that is the cortex, the lesions that are affecting the cortex or the corticospinal tracts, that will result in decorticate posturing. So one more time, decerebrate posturing means complete flexion. complete extension, while decorticate posturing means arms are flexed while this is extended, right? So you can see this in the wards. If you carefully analyze the patient, you can see some of the patients after, especially after road traffic accidents and all, there would be this posturing would be there, right? Now, so that is about the altered sensorium. Now about the seizures, right? So if the patient has a history of seizure, you should ask for the history of tongue biting, uprolling of eyes, frothing from the mouth, urination, or any confusion, post-ictal confusion after the seizure. That indicates that the person had a seizure, and if there is a seizure, that again localizes it to the cortex. So what is seizure? Seizure is nothing but a paroxysmal event due to abnormal, excessive or synchronous neuronal activity in the brain, right? And what is convulsion? See, remember, you have to know the difference between a seizure, a convulsion and an epilepsy, right? What is convulsion? Convulsion is just the motor manifestation of the seizure. What you see, the jerks, right? The motor manifestation, that is the convulsion. And what is epilepsy? Recurrent seizures describes a condition in which patient has recurrent seizures due to a chronic underlying process, right? So that is epilepsy. Fine. So if the patient is having an episode of seizure, has a history of tongue biting or uprolling of eyes, frothing from the mouth, urination, and all, you can confirm that it was a seizure, and that localizes your lesion to the cortex. Now we will come to a very important topic, that is aphasia, right? So what is aphasia? Aphasia is nothing but it is a defect of the language function. There is loss or impairment of production and or comprehension of both spoken or written language, and it includes both verbal as well as non-verbal communication also, right? Let us see how the speech is produced. See, the cortical areas of the dominant hemisphere, they do play an important role, right, in the language production. That is the vernix area as well as the Broca's area. So the visual image of a word, when you are seeing a word, the visual image is projected from the visual cortex into the visual association areas, and from the visual association areas this is projected into the angular gyrus, and from the it is projected to the angular gyrus, right? From the angular gyrus the further processing takes place in the vernix area, right? Vernix speech area, where the auditory form of the word, right? The auditory form of the word is recalled, and then through the arcuate fasciculus this information reaches the Broca's area. See, the arcuate fasciculus is nothing but it is a bundle of nerve fibers that connect the vernix area with the Broca's area, right? So the information from the vernix area is transferred to the Broca's area through the arcuate fasciculus, right? So now, I have told you, from the vernix area this reaches the Broca's area, and from the Broca's area this goes to the Prefrontal gyrus, where the vocalization mechanisms are controlled, right? So the motor cortex, where the vocalization mechanisms are there, that is to produce the speech, right? So to understand aphasia, you need to focus on these three terms, right? Comprehension, fluency, as well as repetition. Right. So what is comprehension? So let me tell you, if there is a lesion of the vernix area, what is vernix area? It is the sensory area. So if there is a lesion of the sensory area, the comprehension is going to be impaired. That is the understanding. The patient is not able to understand what you are speaking, right? So the comprehension is impaired in case if there is a lesion in the vernix area. But the fluency is normal, or the word formation is normal, because Broca's area is normal, right? So the word formation is normal and the repetition is impaired, right? So comprehension is impaired, fluency is normal, repetition is impaired. That is vernix aphasia. So the patient, so what will be the characteristic feature in case of vernix aphasia? The patient will be speaking fluently, but the statements will be irrelevant to what the questions you are asking. If you ask him something, he will answer for something else, right? So that is vernix area. See, if you, for example, if you ask what is the time now, he will say, yeah, I went to the market yesterday. Like that, you know, whatever he is saying is not an answer to your question, right? So that is, the comprehension is impaired, but fluency is normal. He is able to say that, right? And in these patients of Wernicke's aphasia, you have the paraphasias and neologisms. What are those? Paraphasias are nothing but, you know, the patient, due to his difficulty in retrieving the desired word, he will put on a wrong word. For example, instead of saying she is my wife, the patient would say she is my husband, right? Just like that, you know, he's just putting a wrong word because he's unable to retrieve the correct word or the desired word, right? So there will be, that is called as paraphasias. And another important thing is that there will be neologisms. What are neologisms? Neologisms are nothing but the patient starts using non-existent words. That is, the words that are not there in any in dictionary of any language, right? So they will be using such non-existent words, and this is right. So that is neologisms. So paraphasias and neologisms will be seen in case of Wernicke's aphasia. So this is also called as the jargon's aphasia. Simply, this is jargoning. That is jargon type of speech, right? So that is, the patient is not responding to what you are asking. He is just simply saying something. So that is jargon speech, right? Jargon's aphasia. Now, so that is the Wernicke's aphasia. Now the Broca's aphasia, right? Or the motor aphasia. So in the Broca's aphasia, it is the motor speech area. So what will happen? The word formation or the word output, the fluency is going to get impaired, but the comprehension is intact, right? Normally the word output is considered to be 100 to 150 per minute, right? So this patient would be having a telegraphic speech, right? Because to find the word, you know, there will be a word finding pause, but the speech will be usually informative. Because comprehension is normal, the fluency is impaired. He is not to speak fluently, but what he speaks is informative, right? So that is Broca's aphasia. So this type of speech is called as a telegraphic speech. Using minimal words he will speak, right? Because comprehension is normal, fluency is being impaired, right? And repetition is also impaired. So repetition is impaired in case of both Wernicke's as well as Broca's aphasia. Now another type of aphasia is called as the conduction aphasia. Conduction aphasia occurs due to damage to the arcuate fasciculus, right? So once there is damage to the arcuate fasciculus, the Broca's area as well as the Wernicke's area are intact. That means the comprehension, the fluency is intact, but only problem is that the repetition is impaired, right? So that is the conduction aphasia. Now another term is global aphasia. What is global aphasia? Simple. All these three are impaired. Comprehension is impaired, fluency is impaired, repetition is impaired. How does it occur? When there is a large insult to the brain, that will knock out all the language areas, right? So if the lesion, all the language areas are gone, you will have a global aphasia. The person is not able to understand, not able to speak out, right? So that is global aphasia. Now, see, this is a table that helps you to easily understand the aphasias, right? So in this table you can draw a table like this. On the left side you can write fluent speech. Speech is fluent, not fluent. Comprehension is good, comprehension is poor. So there is fluent speech, comprehension is good, and this diagonal, right? This diagonal, above the diagonal there is poor repetition, below it there is good repetition, right? So in Broca's aphasia, Wernicke's aphasia, conduction aphasia, there is poor repetition. Fluent speech with good comprehension, that is conduction aphasia. Fluent speech but comprehension is impaired, Wernicke's aphasia. And if there is a non-fluent speech, right, but comprehension is good, that is Broca's aphasia. Now there are another group of aphasia that are called as the transcortical aphasias, right? So that is transcortical sensory aphasia, transcortical motor aphasia, as well as mixed transcortical aphasia, right? So in these transcortical aphasia, similar to the Wernicke's and Broca's aphasia, they are almost similar, but only difference is that the repetition is good. The repetition is not impaired, right? So why does this type of transcortical aphasias occur? See, there are some areas in the brain. You know, this is actually the blood supply of the brain. We will deal it with later. Still, the anterior cerebral artery, you have the middle cerebral artery and the posterior cerebral artery. These are the major arteries that are supplying the cerebral hemisphere. right? So there are some regions in the brain that are called as the watershed areas. And what are these areas? These receives dual blood supply from the branching ends of the two large arteries. That means, from the posterior cerebral artery, the middle cerebral artery. So the branching ends of the arteries from they receive dual blood supply, right? So these are the from these areas receive from the ends of the arteries, right? So these border zone regions in the brain have a blood supply when comparative to the other regions is reduced in these areas, right? And so the strokes that occur in these areas are called as the watershed strokes, right, in the border zone areas. Now in the watershed strokes, the ischemia is localized to these border zones, right? So once there is a lesion in the watershed areas, now this will disconnect. It is actually what you can say, disconnecting the Broca's as well as the sensory areas, right? The vernix area and the Broca's area are being disconnected from the other part of the cerebral hemisphere, right? So that is from the other part of the cerebral hemisphere you don't have anything. So that is disconnected. So this results in transcortical aphasia. This is the reason for transcortical aphasia. And another important as well as in fact the most common type of aphasia seen is anomic aphasia, right? That is, the person is not able to name. Naming is defective. That is, he is unable to recall the names of familiar objects or places. He can describe it some way, but he is not able to tell the name. What is exactly? So for example, if you show him a pen, he will say, yeah, it's a long object. It's having a cap, or he will say it's a long cylindrical object. Like that he will be describing it, but he cannot say that it is a pen, right? So that is anomic aphasia. And what is the most common, the common causes for this anomic aphasia? Physiologically it includes old age. In the older age this anomic aphasia often develops, and in case of Alzheimer's disease also this anomic aphasia is there, and in case of chronic vascular insufficiencies, right, the strokes, chronic vascular insufficiencies also can cause anomic aphasia, right? So now we will come to apraxia, right? So we have finished all those symptoms: altered sensorium, seizures, aphasia, right? If there is apraxia, now we will deal with the apraxia. So agnosia, I have told you, visual agnosia, auditory agnosia, all those things, right? And loss of cortical sensations, astereognosis, agraphesthesia, all these are the cortical symptoms. Now we have the only one to deal with, that is apraxia, right? So what is apraxia? Apraxia is the inability to perform a learned motor act in the absence of pyramidal, extrapyramidal, cerebellar or sensory dysfunction. See, there is no pyramidal lesion, there is no extrapyramidal lesion, there is no cerebellar lesion, there is no sensory dysfunction. Still the patient is unable to perform a learned motor act, right? So that is called as apraxia. Now what are the different types of apraxia? So the most common form that is encountered in the clinical practice is ideomotor apraxia, right? So what is ideomotor apraxia? There is dissociation between the idea of a movement as well as its execution, right? So both the idea as well as execution is gone, right? So how will you test for this ideomotor apraxia? See, the testing includes mainly 3 stages. So in the first stage, the patient performs, you are commanding the patient, you are asking the patient to imitate the use of an object. For example, a hammer, right? So you are asking the patient to imitate how you use a hammer, or asked to imitate how you use a comb. So the person will not be able to carry out that movement, or he may be clumsy, or he may use the body part itself as an object. For example, if you are asking him how will you use a comb, he will just run his fingers through the hair, right? So like that, that is in the first stage. And if you are asking how will you use a hammer, he will just pound the fist, right? He's just going to pound the fist. That is, he knows, but he is not able to express it, right? So that is the dissociation between idea of a movement and execution. So in the second stage, now you are showing him the action. The examiner is showing him the action and how to imitate to comb a hair, right? So you are showing him the action and then he will be able to perform it. And in the third stage, you are giving him the actual object. You are giving him the hammer, or you are giving him the comb. Then most of the patients, they perform normally, right? So that is ideomotor apraxia. Between the idea of the movement and its execution, there is a dissociation, right? And this is seen in lesions of the dominant parietal lobe, right? And it is commonly associated with aphasias, right? I've told you in the, we were discussing about the dominant parietal lobe. Apraxia is a feature, right? So the ideomotor apraxia mainly comes in lesions of the dominant hemisphere, and it is commonly associated with aphasia also, right? So the second one is the ideational apraxia, right? What is ideational apraxia? There is deficit in evaluation, deficit in execution of a goal-directed sequence of movements in patients who have no difficulty executing the individual components of the sequence. I'll tell you what is it. See, if you are taking a pen, right? If you are asking the patient to take a pen and write, right? So so there is a sequence, right? The sequence of uncapping the pen, placing the cap at the opposite end, and turning the pen towards the writing surface, right? And writing. So this much things should happen if you ask the patient to take a pen and write, right? So this sequence of events is disrupted. So he will be able to take the cap, but he may write with the, sometimes he may not take, he will just take out the cap and he will not turn the pen. He will write with the opposite side, or he may even write with the cap closed if you give a pen, right? So that is ideational apraxia. The individual components are okay, but in a sequence of movements he is not able to do, right? So that is mainly seen in confusional states as well as dementias, ideational apraxia. Now dressing apraxia, that is the person is unable to wear the dress. It is seen in right parietal lobe lesions. I have told you dressing apraxia, constructional apraxia, both are seen in the non-dominant parietal lobe lesion. Both are features of non-dominant parietal lobe lesions, right? So non-dominant, usually we say because it is right, because it is common in the population, right? So in right parietal lobe lesions, you will see dressing apraxia. Also there will be constructional apraxia, right? Constructional apraxia is difficulty in copying simple line drawings or simple building blocks, simple blocks, okay? So for example, the person is asked to draw a star. Initially, this is a sequence, this first was on 9th of May, 11th of May, 14th of May and 30th June, right? You can see how the patient improved, right? Initially when he was copying this, he used to copy like this, then it again improved, and finally he was able to draw, right? So this is what is called as constructional apraxia, right? There is difficulty in copying the simple line drawings, right? So all these are the cortical symptoms. Any of these symptoms are present, you can confidently say that the lesion is in the cortex. So that's all in this video. If you feel that you have benefited from this video, please do share the video, because maximum students would get the benefit, and of course my effort is also fruitful, right? So thank you and see you in the next video.